Hi everyone, my name is Professor Rhonda Wilson and I would like to welcome you here tonight. Welcome to our social emotional wellbeing for First Nations women and gender diverse people yarning circle tonight. Today is World Day for Cultural Diversity, for Dialogue and Development, and it seems to me an excellent day to be having a dialogue that is about cultural safety and cultural diversity. So I'd like to tell you a little bit about what you'll experience this evening in this yarning circle. And if you haven't experienced a yarning circle before, then I'm just going to explain a little bit about the yarning process. So right now we are kind of preparing for our yarn, and in a moment we'll do some cultural protocol. You might be familiar with that as an acknowledgement of country, for example, but we will attend to cultural protocol as the first and very important action of our yarning circle. We'll then move through to a bit of a social yarn with the panel that will join me tonight. And that social yarn gives us an opportunity to get to know one another a little bit and to form a trust with each other and to develop some safety in the conversation that we have in a moment. Then we'll move through to more of a topical yarn, and the two topics we'll explore tonight are about perinatal social emotional wellbeing and perimenopause menopause social and emotional wellbeing. Towards the end of our yarning circle, we will develop some new knowledge, and actually the panel doesn't know exactly what that new knowledge will be tonight, but it will emerge through our deep and reflective discussion and our mindful listening and our attention to each other. The panel is made up of healthcare professionals, all First Nations people, and we will bring all of our collective knowledge to the yarning circle, and out of our discussion we hope to be able to produce some new knowledge. And that new knowledge will then move into the final phase of the yarning circle, where we will find a way to respectfully conclude the yarning circle, and we will leave the yarning circle with some action about ways of remembering what it is that we have discussed tonight. So that's a little setup for you about what we're going to be doing. And so now I'm moving through to our cultural protocol. And the cultural protocol is I'd really like to acknowledge elders past, present and emerging on whatever country that you are listening to this yarning webinar on today throughout Australia. I'm sitting on Darkinjung country on the central coast of New South Wales, where it is very, very wet at the moment, flooding further to the north. But I would like to pay a special respect to elders in the country where I'm coming to you from. As a Wiradjuri woman, respect is a very important aspect of culture, and we have a special word for that in Wiradjuri language called Yindiyamara. And it is a very deep respect and an attentive and deep listening respect and a love that we put into our work as well. So I would like to pay respect to elders past and present and acknowledge traditional countries all over Australia of the Aboriginal and Torres Strait Islander people. I'd now like to move into our social yarn, and on your screen you'll begin to see the panel members that are coming into our yarning circle tonight. And I would like to acknowledge our fabulous chat room facilitator attending to the online yarn tonight as well, Dr. Guy Cameron, who I gather has been working with you all for some time while we dealt with the technical difficulties earlier. So a big shout out to Guy. I think that he has already done a fabulous job in paying respect and bringing our yarning to life. But right now, I would like to tell you a little bit about myself as tonight's facilitator. I'm a mental health nurse, a credentialed mental health nurse, and I've been working in nursing for about 38 years. I'm Professor of Mental Health and Nursing at RMIT University, and I'm also the President of the Australian College of Mental Health Nurses. My work is largely in mental health nursing, my research work in mental health nursing, in digital health, First Nations social emotional wellbeing, and menopause. And I look after a large team of PhD students, some of whom are First Nations people as well. And for me, that work is indeed ceremony, and it is my goal to produce as much scientifically sound evidence to support health practice and mental health practice going forward, with the goal of improving the health and mental health outcomes of First Nations people. I'd like to introduce you to Professor Donna Hartz, Dr. Kirsty Jennings, and mental health nurse Katrina Ward. And Donna, I might start with you if that's okay. Could you tell us a little bit about yourself and who's your mob and where you're from?
Yeah, I'm Amalia. That's hello friends in Gamilaroi language. Excuse me, a bit nervous and I've got a bit of a frog in my throat. So I'm my Nana's country is Gamilaroi, or also in some areas it's called Gomeroi, and I'm Professor of Midwifery and Clinical Chair of Midwifery at Western Sydney Local Health District and Western Sydney University. I live up on Darkinjung country, so I'm coming to you up on the Central Coast of New South Wales. And much of my work in research has been in birthing on country services, and prior to that, continuity of midwifery care for women, which is holistic wraparound, ensuring that the women have good clinical and wellbeing outcomes. And more recently, some of my work is around smoking cessation in pregnancy, in particular for Aboriginal and Torres Strait Islander mothers, and breastfeeding support services. So I think that's probably enough for me. Thanks for having me. I'm really excited to be yarning with you all tonight.
Oh, it's fabulous. Thank you. And Dr. Kirsty Jennings, where are you from? Who's your mob?
Weeaboo. So my name's Kirsty. My mob are Biripi people of the nation is Intari, mid-north coast. Unfortunately, very flooded at the moment here in New South Wales. I'm originally trained as a social worker and worked in Aboriginal mental health in Kempsey, which is also on the mid-north coast of New South Wales. And I retrained in medicine and got my fellowship as a general practitioner. So now I work in general practice. I am a academic and teach into the medical program at the University of Newcastle. I work privately and I also work as a staff specialist in justice health, which is a passion area for me. So I'm incredibly interested in talking about social and emotional well-being and how really that helps us get better health outcomes for our mob.
And it's fabulous to have you with us tonight. Thank you so much. And Katrina Ward, Treen, Mama T, Mama Treen.
Yeah, save the best to last.
Who's your mob? Where are you from? Save the best to last.
Yeah, I'm Treen. I originate from out in the Nampa Wangapuan people from Wangaiba Nation on the other side of the Bogan River. We line up against with the mighty Wiradjuri country. Tonight I'm here on Wiradjuri country down in Bathurst where it's a bit wetter. So I pay my respects to all our mob around here as well. But I've had a long-standing history of working within mental health and social and emotional wellbeing in our remote and rural areas. Currently I'm the Chief Operations Manager for the Brewarrina and Walgett Aboriginal Medical Services. So I see a lot of issues occurring there within our social emotional wellbeing from our First Nations people. And, I'm really passionate about trying to pull together our holistic health models and to try and bring back together our culture as such and just our reconnection back to country for all our people, but particularly our young people. I'm also fortunate enough to be doing my PhD at the moment and having the wonderful Rhonda as my chief supervisor. So she's a mighty strength behind there and keeps the whip out at me, but that's all good. And it's all about, trying to get those better health outcomes for our mob and trying to improve overall and close this gap they've been trying to close for the last 30 years. Yeah.
Oh, thank you so much, and it's just such a privilege to be here tonight with you, Deadly Women, and thank you so much for your time. I'd like to just give a little bit of information, if I can, about why would we be interested in First Nations women and gender diverse social emotional wellbeing, and I guess, it's Aboriginal ways of knowing, being, doing and belonging that we are very interested in inclusion and diversity. And so, some of these things that impact social emotional wellbeing for women are certainly going to impact gender diverse people as well. And so we're mindful of that, and we're paying attention to a diverse intersectorial group, I suppose, embedded within an intersectorial approach when we think about wider health spectrums across Australia. So we're really interested in that inclusion and diversity. I've been looking at a few stats lately, and one of the interesting but not good stats that I have noticed from the mental health dashboard, the annual mental health dashboard that we get from the Commonwealth, tells us that mental health concerns are rising for women in Australia, and in particular, almost half of young women in Australia under the age of 34 now have a mental health condition. Now, that is a steep climb from the period of reporting previously that was sitting at about 26%, I think. So it's almost doubled in the space of a year. And certainly as we've transitioned out of COVID and mental health and social emotional wellbeing has been on the climb, I suppose. So that's for all women, all young women in Australia. But when we think about First Nations young women, what we are seeing, and some of the research we've done locally in the region where I live, is we have looked at the mental health presentations in ED of First Nations and indeed the whole population. But the thing that we really noticed about First Nations people and First Nations young women was that there was that matching steep incline in presentations in ED for mental health presentations for First Nations young women. And there has been an increase in suicidal ideation and self-harm for First Nations young women as well. So I think that that is a very big concern for us. And we know in First Nations cultures that mothers and aunts and grandmothers do have a special role in the community as well. And the other thing that we know about social emotional wellbeing is that cultural safety is linked to the social emotional wellbeing outcomes for First Nations people. So where we see poorer cultural safety, then we often see poorer mental health or social emotional wellbeing outcomes, and indeed broader health outcomes as well. So we know that cultural safety is very, very important. Now I'm going to move us on to this topical yarning, and so we've got two topics for you tonight. The first one is perinatal social emotional wellbeing, and That perinatal period is from conception to the baby's first birthday. And so it's that whole period that we're interested in around social emotional well-being. And I want to tell you about a colleague of mine. Her name is Chris, and she's a Torres Strait Islander woman, and she's a very experienced mental health nurse. And in fact, when she became pregnant just after 35 years of age, she had fairly robust mental health and social emotional well-being. And was quite well informed about the topic as an experienced mental health nurse herself. But her experience of that perinatal period, she found that her social emotional well-being deteriorated significantly. And part of that was, she said, she felt odd, and she was denoted with all of these risk factors that, you know, the risk factor was she was First Nations, then she was over 35, she was obese, she had diabetes. And all of these were denoted in the negative as risk factors. So while she had positive social emotional well-being to start with, it started to deteriorate with this negative discourse. And then even when her blood pressure and her blood glucose levels were stable and within normal range, she was still negatively framed, because people were saying to her in maternity services, for instance, why isn't your blood pressure high? Why don't you have, high blood glucose levels? And then she was warned that her baby will be too small and that she should even think about preparing for a stillbirth. So she had all these professional forecasts that eroded her social emotional well-being, and her hope dwindled. And over that perinatal period, she experienced depression. And one of the things she really yearned for was a closer connection with women's business, but public health services wouldn't allow her to have those aunts and mother and grandmother to support her. And one of the things that helped her recover in the end was to go back to country and to connect with that strong women's business. And that supported her in her social emotional well-being. So I guess I just wanted to maybe throw to Donna. What are some models that might be able to privilege First Nations experience and do something about this negative discourse that people like Chris might experience?
Look, I think we all know about the nature of most health services. We're dealing with a colonization or post-colonization period. And although well-meaning, we still have services that have got policies and procedures and that work counter to the safety of our First Nations women. And then on top of that, we're plagued with unconscious biases and overt biases and outright racism. I mean, we've got a huge body of work that talks about racism kills. So when you look at your colleague going to seek care in a time where they are seeking knowledge, they're seeking relational care. We know that works, the relational care, because pregnancy and childbirth is a time of enormous hormonal change, in particular with the role of oxytocin and prolactin. And we know that those hormones can be they're connecting, the love and connect hormones. So when we end up with stress that counters that, we end up with a very unwell woman. And then that also influences the intrauterine life. So you think about our growing babies, that when we have women that are living with complex stress, and what you're talking about is over discrimination within the service, which causes a layer of stress and distress, that the stress hormones that are released through the HPA then become activated across the intrauterine and the placental barrier. These hormones go into the amniotic fluid. The baby becomes awash with stress hormones. So we end up with a mother who is stressed. And if you think about this, your friends is in quite a solid and health and well-being state originally. That's been impacted and will impact the baby and has impacted her life. When you think about the impact for the majority of people there, and for our mob, they're often dealing with a lot of complex life situations, and they then have also got those hormones that are awash with the baby growing. And what that does, when you have those stress hormones in utero, it affects the epigenetics of that baby. It actually affects them on a cellular level. And we know that with the turning on and off of genes in utero, it affects long-term chronic health. And what's the biggest killer of our mob? So we know that the services that protect women are relational care. Now, some of the early work that we've done for women generally is around continuity of midwifery care and continuity of care models, where the women have somebody they know caring for them. They have all the services that wrap around them. When we take this concept and place it within the Aboriginal and Torres Strait Islander space, it may be in mainstream services, but we would like to see more of it in the ACHO, or the Aboriginal Community Health sector. Is that we know that when we have cultural support and connection, and often it could be one of the ARNIs, one of the Aboriginal health workers or practitioners, working alongside midwives who are specialists in birth, working alongside doctors and social workers, depending on the needs of the woman. But what we know is once we have that woman in that relational, therapeutic relationship with a midwife, with her Aboriginal navigator or spiritual cultural navigator, when we know that everything that comes up for that woman, whether it's housing or DV situations or Centrelink or mental health problems, if we can enable that wraparound holistic service, we know that it produces outcomes. Now, the phrase that's been utilised these days is Birthing on Country project. It's a national project, and that phrase in itself was brought to life by from the early work of the Inuits in Canada, but adapted by elder women at a gathering in Impatwa, which is modern day Alice Springs, and they endorsed birthing on country as a concept, which is not about necessarily giving birth, next to this beautiful swollen river here for me on Kamilaroi country, but it could be, if that's anyway, if it could be, it's about giving birth and getting the best start to life. So it's a metaphor for the best start to life. So the models of care for birthing on country, whether it's with an Aboriginal medical service or in mainstream service, if we can provide continuity of care with a midwife, with a cultural navigator, and with all the services that the women need, that we know that this can produce better health outcomes and in particular well-being. So remember, our mob have a lot of their babies taken away from. We are overrepresented in the child protection space, causes another level of angst when approaching mainstream services, and nearly, most women will give birth in a hospital. So they're under that whole strict gaze of, are you a good enough mother? Are you complying with medical practice? And when you have that wraparound service, that cultural navigator, that midwife holding the ground for them, it enables them to be able to have their own identity and have a level of de-stressing or de-escalating to enable the newer hormonal mechanisms to work better and more efficiently. But most appropriately, we find that with these services, we're able to produce, like I said, better clinical outcomes like reductions in
Beautiful.
preterm birth, bigger babies, they grow healthier
Beautiful.
babies because they're born at term and they don't have the stress. They're more likely to breastfeed, which in itself gives that long-term effect and that bonding with the baby, with the oxytocin and the prolactin. And it enables women to go forward in the world, as we all know. For many of us that are mothers,
Mm.
we know that being an early mother, even when you're in a privileged position, is difficult. So for those of our mob that are not in a privileged position and do have all of those complex health stressors, it can be even more difficult. And the continuity goes beyond the birth. It goes into the early childhood period. The importance is connection. Our culture is based on connections and relationships and feeling safe. So being able to support those women and their families to get the supports that they need, and that includes the fathers or the significant partners. And really important to remember that for mob, it's an extended family. It's not usually one mother or one father. Sometimes there can be a few. You heard Rhonda talk about Mama Treen there
Mm.
before. She's a mother to many of our mob out
Mm.
on her country, and sometimes there's lots of different aunties, and they may not be familial sisters or brothers or aunties or nanas or mothers, but they're cultural and spiritual. So I think
Yeah.
the
Thank you.
services that we
Thanks,
know,
sis. That's
yeah, when they provide continuity of care and wraparound services.
yeah. Yeah. No, that's beautiful description. Thank you so much. Kirsty, what about the diagnostics, I suppose, that clinical interface and framing of a First Nations mother in that perinatal period by her biometrics and diagnostics? How do you see that fitting or not fitting?
I think you're absolutely right. I think it doesn't fit anymore in our changing environment. And what I'm loving now is that as health practitioners, we're really moving towards understanding strengths-based perspective in working with community. And as I think you mentioned, a lot of deficit discourse sits within particularly medicine. And we also talk a lot about, or I've heard talk about, indigeneity as a risk factor for disease. And I think we need to really unpack that and say indigeneity is not a risk factor for poor health. Aboriginal and First Nations people experiences of those social determinants of health put them at higher risk of developing poor health outcomes. We need to really differentiate those two things so that we're not asking people, well, you should have high blood pressure based on just your background. What are we framing in terms of this woman's strengths? And we know from a lot of research that is out there, culture is a protective factor for people for social emotional well-being outcomes. So her connection to home, her connection to her mob, and preferencing elder and women's knowledge in the community is important. So I think we need to move away from that biophysical parameters that we have had it for so long and think about more strengths-based perspective and when we're working with people. And I absolutely agree with Donna, it's relationships. If we can have great relationships with our patients, if we can really work on concepts around clinical yarning and developing great communication skills for health workers, we really start to break down those barriers for people and really get to the heart of what's happening for this poor lady in this situation. And you can understand why, somebody in the system, I think we underestimate the impact of intergenerational trauma in communities and how that impacts people's experience in working with health professionals that have largely been responsible for removing children. So I think we also need to acknowledge our role in that process as medical practitioners and health practitioners and the system that we work within. And as you said, like 48% of children in out-of-home care now are Aboriginal or Torres Strait Islander kids, when we're 3 to 4% of the population. And that rate's actually going up. And so that's really challenging for us as well to think about how a woman can feel comfortable coming into a system that has been so, treated preferentially so poorly, and not want to disclose some certain aspects about how she's feeling about her health. So how we approach that, identifying what strengths are and moving away from that deficit discourse is incredibly important. Of course, we don't ignore any of those physical parameters, but it's only a small part of the piece of that person's experience, and it's only part of the process in working, stepping back as a medical practitioner and preferencing voices of community and other women who have a bigger role, midwives and nurses, social workers, and a multidisciplinary team. Sometimes we have trouble with that as medical practitioners, stepping back and being quiet in a situation. And I think sometimes that has real value.
That deep listening that is so important to us. Yeah, that's beautiful. Thank you so much. And Trine, you're a new grandma again, and you're an important person and grandma and mother to many, really, in rural and regional New South Wales. What's that experience like as a new grandmother and as a mother, as an aunt, as a leader in your community in supporting rural First Nations social emotional wellbeing?
Yeah, look, both Donna and Kirsty, you've touched on great points and all that, and I just need to highlight that for anybody who's working with any First Nations person. And I think my key word to bring home to people is inclusiveness. We need to include the extended families, the outer people who are there, whether it's the aunts or, the sisters, the mothers, the neighbours. We, as Aboriginal people, traditionally, we all brought up that one child. We were all there to nurture that child, to shape that child into its own cultural beings and to become the person it's going to be. And unfortunately, with the way our health system has gone in that, a lot of our people, both First Nations and non-First Nations people, we have to leave our homes to go and deliver our babies, and hence why programs such as Birthing on Country is so important, to get that initial cultural connection to the country of where the person originates from. But particularly in where I originate from, we have to travel at least, 3 to 4 hours to a major regional centre. And, the mainstream services want you there 3 weeks before. So generally that means, uplifting your whole family, either you might have several other children, or you can't leave them back in your hometown, or you can't afford to take them back there. So we, unfortunately, as young mothers and new mothers, we put ourselves at risk because we leave things till the last moment. And, and I've lived that with my own children, where we've done the midnight dash and all this. But fortunately, I've got a bit of medical knowledge there and a big whip to fling them along the way as well. But, it's something that we shouldn't have to expose our young mubs to do. They should feel safe and comfortable to be able to present, whether it's to a local hospital or to a midwife who's willing to do a home birth, whatever their choice is, where they've got their extended family around them and not told, oh, well, you can just have 1 or 2 people there, because it might mean that there's 5 different aunties who are really integral and important to the birthing of this child, and they've all got their own special qualities that bring to support that mum through to the procedure and just the whole experience of, childbirth and motherhood. So we need to, take that on board as well and keep those other people in the loop of what's going on, and particularly, the mum as well.
So I think what I'm hearing is a lot of talk from all of you about an awareness of trauma and intergenerational trauma, but also a listening ear and hearing and exploring where the strengths lie and utilising those strengths, drawing them in to bolster social emotional well-being of not just that woman, but her whole network and community and mob around her. So, beautiful discussion. Thank you so much. I wonder if I can move the discussion to now a slightly older group of women in that perimenopause and menopause phase of life. So I'll just give you a little bit of context about menopause for First Nations and gender diverse people. And to date in Australia, there has only been one research study done, and it was in country Western Australia about 10 years or so ago. I think it had around about 12 participants, a qualitative study, and it was undertaken by non-Indigenous researchers. So this is a very, very small study, and that's all we have to inform our best practice in caring for Aboriginal and Torres Strait Islander perimenopause and menopause women and gender diverse people. So I think it's quite astonishing that there is a complete absence of research to inform best practice for First Nations menopause. Yet we have, by contrast, 65,000 plus years of women's knowledge and women's ceremony, where we do have understandings about women's business and women's health and well-being and social emotional well-being. So again, we've got this this discord, I suppose. It just doesn't quite fit with our Western health, biomedical health systems. So I think it's a real challenge for us. And just further context, there's around, in Australia right now, there's around about 76,000 First Nations women in that 40 to 54 year age bracket. So that's a lot of women who are likely to be experiencing perimenopause or menopause, and we have no evidence to support the care of those women. And as I mentioned earlier, women in communities, they have a lot of responsibilities. And in addition, when they're working and in employment, they're often working in caring, social assistance, retail, customer service type roles. So there's a lot of investment of social and emotional attention, both in their work, in their community obligation, and then some of the challenges that come with social emotional well-being during that perimenopause, menopause period of life. And of course, there's a lot of unpaid carer roles that these women are attending to as well. So I want to come back to you, Donna, and ask you a little bit about, where does menopause education, and particularly First Nations perimenopause, menopause education, come in a curriculum for any of the health professions? And where did you learn about perimenopause, menopause?
Well, as a nurse and midwife, I was thinking back to my nursing training, which is quite a long time ago now, that we did learn about the reproductive cycle. We knew that menopause happened, but that was it, full stop. And then as midwives, we sort of stop at the 6-week postnatal visit, really, unless, we go and do child and family health. So in terms of managing menopause or providing support to women going through menopause, I think as a postmenopausal woman myself now, you really didn't think about it. We weren't taught about it in school, and we weren't taught about it at university. And it was one of those subjects that our parents and mothers didn't really talk about much. I can not remember my mother ever talking about it with us young women, and we were in our early 20s when she went through menopause. But then, for myself, it was something you didn't think about. It's like when you're having your first baby, you think, well, I'm having my first baby. You don't really think about it. You don't think about it when you're 20, I'm going to have a baby when I'm 30. I'm thinking about it now, the whole experience. It's not until you're in it, you go, oh, right, what do I need to know now? So menopause, it's not until you get into it, you go like, well, there's not a lot of information around. I haven't been taught that much. Nobody's told me too much. So it's been one of those invisible and unspoken, which a lot of women's health is, unspoken positions, phases in your life, or physiological change in your life that is really profound. And I think as we were talking earlier, preparing, you're almost living in two worlds. Because as women, we're behind the eight ball anyway. So when you're a working woman going through physiological changes, and you're still, well, for many of us, we still have to be active members of work. That you can't let your physical ailments compromise you in the workplace. So you become two people. You become inside all the psychological and emotional issues that go on, and then you're suffering with a physical ailment, but you're out there with a mask on, pretending that it's okay. I think now it's really wonderful to see. I think the generation behind us that's now becoming perimenopausal, they're very, very proactive and very vocal about what goes on. You see them as mothers and now as young women whose bodies are going through perimenopause. They're more likely to talk about what's going on, and maybe we've started the dialogue with them too. Because so no, we don't learn a lot about it. Curriculum's not been very kind to us, and in terms of Aboriginal and Torres Strait Islander women, as you said, we're just only trying to get them to have pap smears, we haven't been able to get out to many of the regional and remote areas to have good compliance with reproductive health screening, mammograms and whatever, let alone talk about that business, like women's business that no one really wants to hear about anyone, or you didn't realize that anyone would want to hear about and suffer in silence. So I think we've got a long way to go. A long way to go to educate,
I think
a
so
long way to
too.
go
Yeah.
to lift the community's uh, thoughts and realizations around what's happening for us.
Yeah, and of course, we've got the experiences across the spectrum for women and gender diverse people, the experiences that queer women, transgender people might have. It's going to be very challenging to manage all of that and to manage the load that we have in community, in caring. And also, as you said, maintaining employment. And so it is a lot to take on. Kirsty, I imagine that as a GP, you must see, a lot of First Nations women in that perimenopause, menopause period of life. And I guess that social emotional well-being is one of the challenges that people are balancing all the time. And you spoke earlier about strengths-based. What other gems can you share with us from your perspective about social emotional well-being and perimenopause, menopause?
Yeah, so I think it's a really interesting topic, and I think we were talking previously that people are much more empowered to talk about menopause now, which is great to see. But often when I was at medical school, and most women that present are only really talking about those vasomotor symptoms, the flushing and things that they're getting. So understanding about what actually menopause happens in menopause, what's happening to your body, what's happening to your social emotional well-being. So lability of mood, all of those things, joint pains kind of is not seen necessarily as being menopausal. So often even sitting down with somebody and going through, well, what are you actually experiencing apart from those, often known hot flushes. So things like insomnia, sexual dysfunction, which we don't talk about in menopause, libido, wanting to have a normal sexual function. A lot of women have a lot of shame around that. Vulval care, vaginal dryness, all of those things that women kind of will not necessarily want to talk about because there might be a lot of shame. I often find that women will have that deficit around menopause as well, thinking about, well, everyone says to me that I'm being crazy or that I have this menopausal rage or I've turned into this horrible bog witch. And that's usually from other people outside telling them all of this information when we're not really acknowledging that that is part of that menopausal process and that that emotional component is actually quite a large part of how we even would go about starting to talk about treatments, what is available. A lot of women have very little knowledge about what that might be, and often will think, oh, it's only hormones. And we can talk about, no, there's lots of non-hormonal treatments that we can do. There's lots of approaches at working towards addressing social and emotional well-being within that process as well, and that there is light at the end of the tunnel for this process and how long that might last. So I think there's a very big topic around menopause that we've just avoided, and particularly in First Nations women. I think because, as Tanya said, that we prioritize family, we prioritize being home, going to school, being the parent, doing all of those things well above our own health at sometimes, and to our own detriment at times. But, having the time to be able to talk about ourselves is often seen as being a little bit selfish at times by women. So acknowledging that, no, it's okay to have time for yourself. It's okay to talk about this, and there isn't any shame with that. I think 65,000 years wasn't of no knowledge that we have in women's health wasn't just looking about your follicle stimulating hormone or your estrogen levels. It was about the experience that women were having. So acknowledging experience as part of menopause and not just treating on numbers, I think is really important.
Yeah, and I love what you say about no shame.
Yeah.
That's shame is something that really does impact First Nations people, and the willingness to talk about some of these ideas. And so yeah, that's really important for people to know about, that shame can hold back from revealing some of the challenges that people have. And you've reminded me about sleep as well. And, there's a lot of First Nations people who, have crowded housing, for example. So, and don't have housing security and food security. And when you don't have the surety of that, and certainly in Australia, there is a rising number of homeless older women, and First Nations women are among those people, then just being able to sleep and have that cognitive function, or the cognitive fog that comes with perimenopause, menopause, it's a big ask to manage that in some of the social situations that that we do encounter. So yeah, thank you so much for that. Now, Trine, rural and regional complexity, you talked a lot about that before, but for perimenopause, menopause out in the bush, that's not easy for First Nations women either. Have you got
exactly.
Yeah.
Well, and 9 times out of 10, the services they provide, from a drive-in or fly-out services as such, you might come once a month, and they're there to do the women's business or women's health screening as such. And while it can be a great service, it all depends on those people who 9 times out of 10 are not First Nations people, but it's doing that background work and building those relationships. You've got to, it all comes back to having that relationship first, getting that trust involved, building the rapport for people, feel comfortable to come and talk about, the shame that is associated with, perimenopausal and menopausal women. For an Aboriginal woman to be able to share what's going on within their, life at that time, it can be quite a burden for them. So they'll either just reluctantly not see anybody and, suffer along the way. And then the whole social emotional well-being becomes affected because they're ultimately going through a period of loss and grief. And I think that's where a lot of our GPs and that, they don't see our menopausal women and our perimenopausal people as having this loss and grief. They're losing the function of body parts that is integrable to us as First Nations people. We are the mothers, we are the nurturers. We are there to keep our, bloodlines and our storylines following through from a cultural perspective. So once we start going through those changes, it can become a deep transgenerational loss for us as well. So I really believe that, that impact needs to be taken into consideration as well when the full assessment is occurring, whether it be by, women's health nurses or whether with the GP and that too, and what they wish to try and prescribe or whatever care they want for these individuals, because we need to take that on to focus. And I just also, with the experience of all your hormones and that changing, we've also got a big line of children in there as well. So we've got it where there's other family members who are having hormonal changes and balances. So the whole family can become disrupted. And as you touched on, Rhonda, with the overcrowding, that's a major burden, with our women to be able to feel safe or culturally safe, particularly if the house is full of, males and other young people around them. They may not feel comfortable to be able to explore their own self and their own social well-being.
And just that access to toilets as well. I mean, it's a really critical time, isn't it, to be able to have good access and safe access to something as simple as an accessible toilet, for instance. Yeah. So there's so much information that you've all shared, and I guess now we want to come to what have we learnt tonight as we've discussed these really complex topics, and they are really complex. Is there some knowledge that as we bring our ideas together that emerges that can take us forward with some clues about how to respond to social emotional wellbeing for First Nations women and gender diverse people? And I guess I come back to everybody on the panel again. What are the real takeaway pieces of knowledge that are going to be really important moving forward? And we're coming into that forming new knowledge part of our yarn.
Well, I'd go straight up, and it's part of the yarning process. It's that deep listening, as physicians and clinicians, we need to listen to what our people are trying to tell you, what's happening in their life, and not be dismissive of what they might be feeling. You need to take all that on board and build those relationships.
Relationship and deep listening. I think that's incredibly important.
I think that ties. Sorry, you go, Chris.
Oh, sorry, I absolutely agree. And I think the cornerstone of relationships is communication.
Yes.
I think that really is important. We can be the best clinicians in the world, but if we're not communicating clearly with First Nations people, we're not going to get anywhere. I think it's incredibly important skill to learn, and to learn to focus for a patient-centered model of care. We're looking at trauma-informed care and being very open to changing the narrative that we've had in health for so long around that deficit discourse, and really concentrate on strengths-based, collaborative, patient-centered care, and work on our communication. For me, that's the most important cornerstone of all interaction with our mob.
Oh, so that's beautiful.
And women need to feel culturally safe, and that's exactly all of what Kirsty and Trine had just listed, pretty much. That they will not come for care if they're not feeling that they're being respected, if they don't feel a connection, if we do not have First Nations workforce there that can understand or encourage the non-Indigenous workforce to have insights. And I guess this is a part of this yarning. So the takeaway here is, how can you listen and enable mob to front up and have their stories told so they feel safe. And when you look at once their stories are told, there was another layer, as you're talking about, and we're going to the menopausal women, is that the other story, like we're talking about them being homeless, that economic crises that they can end up in because of their physical ailments, not being able to purchase menorrhagia in menopause, but also the loss of work because they can't get to work because they're so unwell. And there is then perhaps a loss of relationship because their libido goes down. There is so much flow on. So I guess that providing that safe, culturally safe environment for them to express, and then going back to that wraparound services, what's available to support them, whether it's from it's medicine or alternative medicines or yarning, counselling, whatever it is they need, listening and trying to help them to find their way forward.
Oh, that's beautiful. So I guess, as we come to the end of the yarning circle, we've almost come full circle back again. And, we've talked about how important that social yarning is, that trust and relationship and communication, being prepared to really deeply listen, rather than to assume as health professionals we know best, but actually to give that opportunity to hear and not to jump in too soon with solutions. I think I heard Donna as well talking about, the traditional therapies, and I think, Trine, you were talking about that as well, that we need to have a wider set of solutions to support First Nations women and gender diverse people. What I really want to do now is just, and this is a very important part of our yarning as well, is to express gratitude and respect for all the knowledge that you've shared with us, Donna and Kirsty and Trine, and I know Guy has been doing that in the chat room as well. I just want to really express my very deep gratitude for your time and your knowledge and your willingness to share that with us all tonight. And just to convey my very deep respect for your knowledge. And I guess what we've together talked about today is really a transformation of, it's the possibility of what can be in the future if we listen to First Nations voices and incorporate them in our clinical practice. And I guess there's a new song and a new story to emerge in that strengthens social and emotional wellbeing outcomes for First Nations people. So I would really like to invite our listeners to really reflect on, and it's our job as yarning participants as well to really go out of this yarning circle reflecting on what it is we've discussed, the actual ceremony that we've participated in tonight, in having this deep discussion and hearing each other's perspectives. And it's our responsibility to remain in harmony to that, to the yarn that we've had, and to take that forward in our practice and hope that our colleagues listening in will do the same. So I really want to thank you so much for your participation tonight. And really now that brings us to the close of this yarning circle. I do want to let our listeners know that there is a feedback survey, and we'd be really interested to listen to your experience of participating in this yarn as well. We hope that it was useful for you, and we want to thank you as well for sticking with us and listening, and deeply listening and considering the ideas that we've discussed today as well. So thank you for your deep listening as well. If you are planning on claiming some CPD points, you can access the learning outcomes for this Yarning Circle webinar. It's on the supporting resources tab. I think it's in the top right-hand corner. I don't promise that, but I think it's there somewhere, and I'm sure you'll find it. And you will be sent a certificate of attendance in the next couple of days as well to help you support your CPD claim. But I really want to thank you all for participating and wish you a very good night indeed. Thank you.